Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. I'm really pleased my guest today is none other than Dr. David Nash. I had the pleasure of meeting Dr. Nash at the recent VIVE conference in Nashville. He is the founding dean of Jefferson College of Population Health and a board-certified internist. He's a respected expert on healthcare accountability, quality, and membership. I've become acquainted with his book entitled How COVID Crashed the System, A Guide to Fixing Healthcare, co-written with Charles Wolforth. Dr. Nash, welcome to the Tate Chronicles.
Yeah, thanks so much, Jim. Great to be together.
I've been waiting for somebody to write this book for some time now. And I think there may be enough distance since the COVID pandemic. And I want to thank you for doing this book and publicizing this book. It's important.
Well, I'm thrilled to be here and glad you're interested in the book. It's gotten a really great reception. We're grateful that people are paying attention.
You know, back in the, to give a financial analogy, back in 2008, 2009, when we had the mortgage crisis and problems with the banks, the government started stress testing banks. I think the COVID pandemic was a stress test of the American healthcare system.
That's a great analogy. And I think it fared even worse than the financial system.
Well, I think it did. And, we just didn't know where the gaps are going to be until the pressure was applied. So there are a few things in your book I'd like to just bring up kind of as subtopics. We're not going to have a lot of time today, but I want to talk about what, to me, are some of the really important things that we learned about what went wrong. The first of which is in your book, what you call the failure of leadership.
Yes.
Is that political? Is it medical? Is it all the above?
Yes. Well, great question, Jim. It's basically, sadly, all of the above, from the very top of the food chain or the executive branch all the way to the CDC, to the FDA. Early on in the pandemic, there were experts who warned the senior-most leaders of what was about to occur. They were belittled, they were ignored. Sure, some of our listeners remember that the president at the time said, "I'll see you in church for Easter Sunday," right? Mm-hmm. And of course, that never came to fruition in April of 2020, when we were basically 1 month into it. And at that point, we had passed the nearly 50,000 dead in late April of 2020. And here we are 3 years later, almost to the day, and we have 1.2 million dead, more deaths per capita than any country in the world from COVID.
Now, you mentioned in your book that it makes quite a bit of commentary that the American culture makes us more vulnerable.
Yes.
What do you mean by that, Dr. Nash?
Well, we talk about three aspects of our culture in no particular order. American individualism, exceptionalism, and federalism. Let me quickly tackle each of those. So,
sure.
Of course, American individualism is, the notion that we're still in the covered wagons heading out west on the Oregon Trail. We can't wait to see the vast Pacific Ocean. And we are, autonomous beings. We want to claim our own property. You get the idea that
sure.
You can't tell me what to do. That's American individualism tightly woven into our culture. American exceptionalism is, not invented here. We're not going to pay any attention. And in the book, we talk about Jefferson doctors who had close relationships with Italian doctors pre-Christmas 2019.
Well,
And those doctors warned our colleagues here at Jefferson about just how bad it was and what was headed our way. But basically, American exceptionalism was not invented here. We're not interested. And then finally, federalism. And our listeners, I hope, remember when various governors called out their own National Guards people to protect ventilators and shipments of PPE and gloves and all the rest. So individualism, exceptionalism, and federalism cost us hundreds of thousands of lives.
For a historic perspective, you may be able to weigh on this, maybe not, but I'm old enough to just remember the tail end of the polio epidemics.
Yes.
And so during that time, were there, all kind of almost conspiracy theories going around, or kind of outside the mainstream treatments, or is there any comparison, or have we?
Well, that's a great question. We researched this in some detail. And of course, there was no internet, no social media. There barely was, a telephone and very little television also. And you and I are of the same era. So there was, as far as we're able to tell, tremendous respect for Dr. Salk and others in the polio vaccine. It was considered a great American achievement. Remember, we were in the height of the Cold War with the Russians. They had put Sputnik up in space, but we had conquered polio. So it was considered a patriotic duty to get vaccinated. A totally different social and cultural time than the one we're in currently.
And I believe, correct me if I'm wrong, Dr. Salk refused any patent on his vaccine.
That is correct. And he was viewed as a national hero. I mean, it was from a totally different era, obviously.
Well, let's move on to COVID and racism. That's in your book.
Yes.
Yeah. What's the story there, Dr. Nash?
Well, I wish I could sort of just summarize it for you, Jim, but look, America has a complex relationship with race playing out still every day, right? And look what's just happened in the great state of Tennessee with their state representatives. I mean, racism is a part of our culture. There's just no denying it. And we have now a century and a half of issues like structural racism and redlining and lack of access to healthcare for folks in communities of color. None of this is new. But what COVID did, and a deep thesis of our book, is that COVID shined a spotlight on these issues that we have all known about for over a century. Issues like, well, if you're going to have telehealth, you better think about people who don't own a cell phone. If you're going to vaccinate folks, you better think about our pretty sordid history of dealing with healthcare needs in minority communities. If you're going to tackle health as an important outcome, well, you better take into consideration smoking, hypertension, diabetes, obesity in communities of color. These communities were at an incredibly high risk for death and all the complications from COVID, very different from non-white communities. And just incredibly complex problem.
One of the things I heard you mention last week when I saw you being interviewed was the fact that some economic groups were able to work remotely from home, but the cashiers and bus drivers and
that's right.
They were essential workers. Yeah.
Yeah. We learned very quickly, who's essential, quote unquote. In Philadelphia, the real heroes were the lunch ladies in the public schools who came to the public school cafeterias to cook lunch that were then put on the buses and delivered to the local communities. So no children on the buses, just delivering the food to the communities where in Philadelphia, 1 out of 4 people live in poverty. And of those 25% in poverty, half of them live in deep poverty, which means food insecurity. So the essential workers were the public transportation train conductors, the cooks, the folks who stocked the grocery stores.
Mm-hmm.
My wife and I stayed home and I continued to work full time. And we ordered our food and it was delivered to our front door.
Yeah, exactly. Well, let's move on to another big topic, which was public health, which if this was not a public health emergency, I don't know what one would look like.
My goodness. Well, you're totally right, Jim. But as we talk about in how COVID crashed the system, let's look at the underlying pre-pandemic issue, which you could summarize very easily. In 2019, spending on healthcare services in America, 20% of the GDP, roughly $10,000 per person, including children, of annual healthcare spending, $400 per person to support the public health infrastructure. 10 grand versus $400. Is anybody therefore surprised that COVID crushed the public health infrastructure? Let's add then on top of that the political implications and the cultural challenge whereby hundreds of public health professionals fled and left the system because of concerns over their personal safety. An unbelievable 1-2 knockout punch, the finances and the cultural backlash. That's what COVID demonstrated so conclusively.
One thing I would certainly have become aware of from the public health standpoint is usually we think that the public health entities and organizations keep track of certain diseases and perform contact tracing, have registries, who's been immunized, who's tested positive. That seemed like a complete failure.
It was a complete failure. And as my great colleague, Dr. Lena Wynn at George Washington University is fond of saying in her book, public health saved your life today. You just don't know it. And that is true. Vaccination, clean water, hygiene, food safety, all these relatively, if you would, unsexy things compared to heart and lung transplant, breaking the human genome, fighting cancer with your own cells. That's where the money is. That's where the cultural appeal is. That's where folks aspire to work. It's not in what's generally considered to be, sort of the backwater of public health. But it turned out that we needed that backwater more than we needed the temples of technology like the one I'm sitting in right now.
Well, let's touch on one other grave crisis that was part of that pandemic, still continuing, actually. I know some folks have gotten really sick in the last couple of weeks.
Yes.
Ended up with pneumonia. Sick as they've been in their lives, they say. But let's talk about the crisis in the hospitals.
Well, today we have a really interesting and very complicated post-pandemic situation wherein hospitals have spent all the money they emergently received during the height of the pandemic, the CARES dollars. Now we're faced with the inflation for all of our supplies, the great resignation and movement of people out of the workforce, principally nurses, and the fear that a second pandemic could return, which is why in certain fields like emergency medicine, they failed to match sufficient trainees to the available training slots. This is just the tip of the iceberg of what delivery systems or providers or hospital systems, all synonyms, are facing today. Essentially, the model is so broken, in our view, it has to be thrown away and we have to start over. And I would add, Jim, that we've lost our true north. What is it that we're in the business of doing? If our business is to improve health, we have gotten a failing grade. I think that's the take-home message in part from how COVID crashed the system.
Let me mention to our audience, if you're just joining this episode, I'm Jim Tate, and today on the Tate Chronicles, I'm speaking with Dr. David Nash, author of How COVID Crashed the System, a guide to fixing American healthcare. Well, let's turn over the coin a little bit and see maybe some lessons learned or best practices. I'll tell you one thing I'm very curious about is folks would come to the hospital critically ill, and at some point, somebody, or maybe a number of bodies, figured out if they're on a ventilator or whatever, we hit them with a lot of steroids and put them in a certain bodily position.
Right.
And so how did that protocol spread? How did you hear about it? Yeah.
Well, what a great question. So very quickly, we do discuss this a little bit in the concluding chapters of the book.
Mm-hmm.
So every hospital created what we call in the business an incident command center, an incident being like a terrible challenge, like the pandemic. And hospitals had these plans in place. And one of the key attributes of the incident command was daily closure of the feedback loop to frontline troops, doctors, nurses, pharmacists, and others taking care of very ill patients. And so what we saw in real life play out was daily updates, daily willingness to disregard old dogma and adapt and adopt new treatments. And that's how we got to prone positioning, use of dexamethasone, less and less use of ventilators. I mean, it's a tribute to the culture of the incident command, which is characterized by self-evaluation, good data, and immediate closure of the feedback loop using the language that I just used of quality improvement. Yeah. I hope aspects of that will be enduring moving forward. We will see how that plays out.
That saves so many lives right there.
Exactly.
Absolutely. Correct. Yeah.
Right.
So in terms of the other items related to the health system healing itself, you mentioned aligning incentives. What do you mean by that?
Boy, that's a topic unto itself, Jim. But
yeah.
For our listeners, look, there's no question in our minds and the minds of hundreds of experts that we either talk to or reference their work. Private practice fee-for-service medicine is the root of all evil. Now, that's a provocative statement, but the evidence to support it would fill the room I'm sitting in. Mm-hmm. So the incentives to do more and get paid more are harmful, dangerous, wasteful, not productive, and don't improve health. So what we need is to realign the economic incentives and do what we call go upstream and shut the faucet rather than just constantly mopping up the floor. So let's focus on exercise, nutrition, reducing crime, improving education, gun control. Mm-hmm. Those issues will improve lives and improve health.
Well, another topic I was interested to see you weigh in on is the promise and peril of technology.
Well, of course, technology is always a two-edged sword, right? You know, the promise of telehealth works for the already pretty healthy. Mm-hmm. If we're going to make the wealthy healthy, then we will have failed. So that is one of the two-edged swords. The other, of course, is the electronic medical record, wherein if it promotes and continues to be a part of what most folks regard as physician burnout, well, that's a two-edged sword again. So technology is only as good as the folks who can implement it. And now we're staring down, of course, artificial intelligence, chat GPT, and all the rest. So it'll be interesting to see how we harness all these new technologies. And of course, the mRNA vaccine, actually not so much a new technology, but one that had been around for almost 2 decades, but re-harnessed for a new purpose. So technology always is only as good as the folks who utilize it.
How ready? Of course, COVID literally came out of the blue. The first thing we heard was maybe in January of 2020, a nursing home in the Pacific Northwest. And then within a couple of months, it was suddenly announced this could be transmission by airborne. Whole country shut down in about a 48-hour period.
Right.
Totally out of the blue, no time to prepare. And so that is, to me, the happened so quickly, the scariest aspect. And we don't know if there'll be another one like that in our lifetime. We just have no idea. But are we more ready for the next COVID-like pandemic?
Sadly, my own personal view is we are nowhere near ready. Let me give you like a closing analogy, right?
Mm-hmm.
Sadly, let's go back to 9/11, September 11th, 2001, and 3,000 Americans die in one attack in New York and in Washington, D.C. The country creates a cabinet-level post. The nation is totally energized. And here we are, 22 years later, we're still taking our shoes off at the airport.
Mm-hmm.
Just this week, Biden administration is very shortly to declare that the emergency is over. The White House task force will be taken apart. The folks will return to their previous day jobs. And the funding for pandemic preparedness has not been radically increased, quite the opposite. So I would say that there's a famous post-World War II saying, Jim, when the dying stops, the forgetting begins. That's exactly where we are today.
And I believe that's probably the motivation behind you writing your book.
Indeed, that's part of it. And we wanted to create, Charles, in the our version of the historical record with scores of interviews, 500 references, 2 years of work, so that when historians look more dispassionately at what happened, I hope our book will be part of that conversation, part of that discovery.
I know the book is available on Amazon. Is that the easiest place to get it? Or
sure, that's the easiest. There's a Kindle version too, but if folks just go David Nash and put my name into Amazon, up it pops, and we're grateful. All the proceeds from the book go to the Jefferson College of Population.
Well, but you're giving it back. I know it's 5 stars on Amazon. I was looking at it today. If folks want to maybe touch base or get in contact with you to discuss this more,
sure.
How do they reach you, Dr. Nash?
Easy to get to me via email. It's david.nash@Jefferson, like the president.edu. David.nash@Jefferson.edu. If folks prefer LinkedIn, I'm on LinkedIn as well.
Well, we're totally out of time. And to our audience, thanks for joining me on this episode of the Tate Chronicles. Of course, I offer a special salute to my guest today, Dr. David Nash. Dr. Nash, thanks for coming aboard today.
Thanks so much, Jim. It's been a real pleasure.
Been mine also. You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.